Hi everyone, good afternoon. My name is Noah Drew and we're coming to you today from the University of North Texas Health Science Center at Fort Worth. Today's Speakers Bureau presentation features Mr. John Sims, who is the Director of SaferCare Texas and is actually relatively new to the Health Science Center. So John, welcome and thank you so much for being here today.
Thanks for having me today, Noah. I appreciate it. Yeah, as Noah said, I am new to the Health Science Center, and I'm the director of SaferCare Texas. SaferCare Texas is the patient safety division of the Health Science Center. And our mission is to challenge traditional thinking to eliminate preventable harm. And we have a phenomenal team of subject matter experts and thought leaders who collaboratively and interprofessionally are dedicated to that mission. Today, I do want to talk about a very preventable harm, and that's suicide. Can we prevent it? And is our level of awareness to a point where we have an opportunity? And has COVID already had an impact, or will it have an impact? So I want to share a few statistics with you all about suicide. According to worldlifeexpectancy.com, and so this is a database that compiles data from the CDC, the NIH, the CIA, as well as state and local databases. And according to that, suicide is the 12th leading cause of death in the United States and the state of Texas. If you hear that, it almost seems as though, we've got 11 other causes of death that we should maybe be studying and finding solutions for. But if you break down the ages of suicides, it's a more telling story. So between the ages of 15 and 34, it's the second leading cause of death in the United States and the state of Texas. First being poisonings in the United States, and the first leading cause of death in Texas is traffic accidents. But if you look at the age group 35 to 44, it's the second leading cause of death in the United States, but it is the number one leading cause of death in the state of Texas. And I think that's appalling. And I think that we have some great opportunities to impact that. In the age group 45 to 54, it's third in both the U.S. And Texas, second to coronary artery disease and poisonings. Today, I'm going to mention stuff from the QPR Institute. This is a suicide prevention training that people can go through that prepares them for how to talk to somebody who may be contemplating suicide. And so QPR stands for question, persuade, and refer. According to them, the LGBTQ youth seriously contemplated suicide 3 times more than heterosexual youth. Also, in an article in the Military Times, veteran suicides increased 50% between 2007 and 2017, and they are 1.5 times more likely to complete suicide than non-military personnel. There's more. So according to the American Foundation for Suicide Prevention, women are 3 to 4 times more likely to attempt suicide, while men likely choosing more lethal means are 3.5 times more likely to complete suicide. And we know that people with mental health disorders are at high risk for suicide. In fact, untreated depression is the number 1 cause of suicide. This initiative is very personal to me. And the reason is because I lost my oldest son to suicide. And it'll be 3 years this September. And I can tell you, from my experience, I've experienced other family members, friends that have died. Some people have reached the end of their lives via, for their age. There's been even acute deaths, like a car accident or an asthma attack. We had one, which is preventable, by the way. And those are sad. They really are sad. Um, but we were able to work through those. This death, um, we're left with questions we'll never have answers to, and the pain keeps coming back. Um, I try to use this analogy, and I don't. If somebody's had a traumatic amputation, I'm certainly not trying to disparage them. This is the only thing I can think of to compare it, is if somebody had a traumatic amputation of a limb, you go through the associated acute pain and rehab for that, but you never forget. You're always reminded that that limb is never going to be with you, and it was once a part of you. The other reason why this is very personal to me is there have been 3 times in my life, in my late teens, my early 20s, and my early 30s, that I seriously contemplated suicide myself. And so I know what it's like to be in that deep hole where you feel like that is the only thing, that's the only solution that you have. And so this is a big initiative that I would really like to see some improvements in.
Thank you, John, and thanks for sharing your personal story. I think it's very relevant to what we're doing here today. I know that you laid out the case that the data makes for how prevalent suicide is, but I know that just through my discussions with individuals leading up to this webinar, just mentioning what we were doing, I was frankly surprised at how many people's lives have been touched by suicide. So I think it's definitely needed and valuable. And today we'll talk through some of the ways forward or through some of the different topics that you hit on. And I apologize to everyone at the beginning. I did forget to say that we are taking questions at the end, and this will be recorded, and any resources that we do mention will be input into the video recording that's sent out. But we have the chat feature, so if you do have any questions for us at the end, please feel free to engage there. So John, kind of moving back to our discussion, right now we're clearly going through the COVID-19 pandemic, and is there any correlation between recent suicides or and the COVID-19 stressors that people are going through, or is it maybe too soon to tell? Is there any link there between that current event and suicide generally?
So yeah, the simple answer there is it is too early to tell, to analyze current suicides. Are they just an ongoing problem that I just outlined, or are they directly related to COVID? Time will tell. But here's what we do know. Again, depression is the #1 cause of suicide. So what are some symptoms of depression? According to QPR, those are low self-esteem, altered sleep patterns, altered eating patterns, increased social isolation, as well as increased substance abuse and alcohol use. We also know, COVID, we have not experienced this right in over 100 years. But following the Spanish flu pandemic of 1918, there was an increase in suicides. Also, more recently, the 2003 epidemic in Hong Kong resulted in a significant suicide increase in the over 65 population. And researchers actually went into to look at what were some of the reasons. And some of those reasons include social isolation, being a burden to their family, and psychological distress. I have great concerns for our frontline health workers right now who are providing care to patients who are either recovering or are very sick with COVID. They are exposed to a very high volume of people who are extremely sick. They're working long hours. They themselves are very concerned with contracting COVID and maybe taking COVID home to their home. There was a recent editorial article by one of our colleagues, Lily Jelinas, on mental health PPE. And I thought it was great because it outlined some of the emotional concerns and some of the emotional things that we need to do to support our healthcare workers. So when you combine all this with a Kaiser Foundation survey that found that 45% of Americans had increased worry and stress related to corona, I think we have a reason to be concerned. But again, data will tell. I want to share one other thing about a distant family member related to COVID and mental health care. So, and this is in our far westerly counties, and she only has Medicaid coverage, which is a barrier. But she cut her wrist in front of an officer, which took her to the hospital to have that fixed, and then she went to a behavioral health unit, was recommended inpatient treatment, but because of the social distancing restrictions that they have to abide by, she's on a 30 to 45 day wait list. Now, in fairness, they released her to a family member who is there with her 24/7. And so it's not like she was left there, she was discharged unsafely. But that's very telling about the climate of what's going on in our people with mental health disorders getting the care that they need.
Yeah, it's really hard when we talk about mental health because a lot of the ailments are invisible, and so it's easier to maybe ignore or kind of sweep them under the rug or not know about them until it's too late. And if that's true, and also thinking of suicide as preventable harm, what are some of the warning signs that friends or family might look for to be able to step in and prevent someone from hurting themselves?
So that's a great question. So I want to talk about the immediate signs, and these are signs that you need to if this occurs on campus, you need to call the campus police. If it occurs outside of campus, you want to call 911 because these individuals need help immediately. And so those are people who have a plan and a means to carry out a suicide and an intent to die. That's an immediate call to either campus police or 911. This is even more emergent if this individual has had previous suicide attempts. The data escapes me, but there is a correlation between completed suicides and those who have attempted suicides in the past. So this is even more emergent. Another emergent sign is if somebody's overdosed on drugs, whether it be illegal or prescription drugs, or they have already injured themselves. We need to call 911 or the campus police, like I said. Some warning signs that are probably somewhat obvious. If somebody's talking about suicide or talking about killing themselves, now they don't have a plan, but they're openly talking about it. People who are expressing hopelessness or may say that they don't have any reason to live. Extreme feelings of guilt, shame, unbearable emotional and physical pain, withdrawal from friends or family, maybe talking about death an awful lot. Those are some warning signs that I hope that those are more obvious to you. Some of the not so subtle signs are things like extreme emotional shifts. And what I mean by that is, and these are people that you might be around every day. So somebody's kind of got a somber, demeanor about them, and all of a sudden they come in and they're extremely angry. So that warrants a conversation, right? The reverse is true as well. Somebody comes in and they are extremely happy. Now, I'm not suggesting people shouldn't be happy, but if they're smiling and they're laughing at everything, almost in an exaggerated posture, that requires some more discussion. There are some people who have been contemplating suicide, and they will be happy because they have accepted that that is their solution, and now they're at peace with carrying out that solution. So, what do we need to do with those people? Well, again, we need to have a conversation with them, and we need to be comfortable having that conversation. This goes back to the question, persuade, and refer. So, we want to question those individuals about, hey, I noticed that you're very happy. Please share with me what's going on in your life. I want to be that happy too. Or why are you so upset? Can I help you with something? And see if it goes in that direction. For some of these other warning signs that I outlined, these are questions that you want to ask directly. Are you thinking of killing yourself? Are you thinking about suicide? And then we want to persuade them um, to live instead of die. Now, if we do that, um, that does not mean that they are out of danger from suicide, but you very well may have um, relieved them of the immediate danger of taking their lives by suicide. Um, then you want to refer them. And you want to refer them to a counselor, a trusted family member, a friend, a spiritual advisor, a physician. Um, somebody else needs to hear that story. And I would also recommend that you go with them to make sure that they've made that referral. Help them make that referral rather. Sometimes when people are that low, taking steps like that are extremely difficult. So you've already established a rapport with them, go with them and help them make that referral.
So it sounds like, I mean, you've talked a little bit about how to talk to someone who is maybe contemplating suicide or exhibiting warning signs, and maybe it's not emergent, and using, not ignoring and not blowing it off. When we were talking to kind of plan this conversation, you mentioned a story about Kevin Hines. Do you mind sharing that?
Absolutely. Yeah. I mean, Kevin Hines is an individual that I actually got to talk to following my son's suicide. Some people that are listening today may have heard of Kevin Hines. But let me tell you about his story. Kevin Hines he still does have bipolar disorder, and he attempted to die by suicide by jumping off the Golden Gate Bridge. And again, the completion percentage for jumping off the Golden Gate Bridge and suicides escapes me, but I think it's about between like 97 and 99%. Meaning, if somebody chooses that method to die, they're probably going to complete suicide. And so Kevin Hines, he also outlines the fact that before he made that decision to jump, he was sitting there kneeling, crying, obviously very distraught. And people were walking by him and paid him no attention. They didn't ask him, hey, what's wrong? Are you hurting? Can I help you with something? They just acted like he wasn't there, which re-emphasized in his mind that, maybe the world will be better off without him. And so, when he talks now, he'll tell you that he wished somebody had come and talked to him, and he encourages people to do that now. He also says when he committed to jump, that once he was like in the air and he knew that his life was likely going to end, that he had immediate regret and that he did not want to die in that moment. Um, after he was one of the very few who did survive that fall. After he recovered from the numerous injuries that he had, he felt like he had a calling to go out and has this slogan called hashtag Be Here Tomorrow. And so I like to use that example um, really to celebrate kind of his mission for suicide awareness and prevention, but also to remind us to talk to those individuals. Don't ignore people like that because you very well could save a life.
Thanks for sharing that. I think that's really powerful and highlights the importance of, stepping in, intervening, and noticing individuals.
Sure,
Um,
sure.
you talked in the intro a little bit about the questions that survivors are left with, and that you have unanswerable questions. How do those who remain behind cope with losing someone to suicide?
So yeah, that's something that our family went through, and honestly, we didn't even entertain that in the beginning. I stayed off work for 6 weeks. You know, but there are some groups that can help you with that grief. There's one in Fort Worth that we went to for a while. It's called Survivors of Suicide (SOS), and it's in Fort Worth and Tarrant County. And no, I don't know if you were able to put that information on the screen, but the address and the phone number and everything.
We'll
Uh,
be able to in the recording,
okay.
and we can send it out when this goes out. So we can talk about it now, and then we'll actually notate it later for those of you
Oh,
at home.
on great. So yeah, the address is in Fort Worth, and the phone number. What I was going to say is they're doing things obviously virtually now, and so you'll want to call them and set that up. There's also a healing after suicide group, and the only way to contact this group is via email, and we'll include that email at the end as well. But this was a great group that we went through, but it's a 8 week uh, grief group where you learn coping strategies week after week, and each week builds after the other one. So, but I guess if there's a drawback to that is whereas the suicide survivors group, you can go anytime you want, as many times you can not go. You don't have to have an appointment; you just show up. But in this one, because it's an 8 week program, once they have a class for that 8 weeks, then you can't really join in until that's over. So
I imagine in some way that might be nice though, because you do have a cohort, and if you're able to build camaraderie with folks and grow together, I imagine that would be an empowering experience. I know that again, sharing in talking to plan this conversation, you did say it was almost re-traumatizing to see people who were newly dealing with the stress of losing someone to suicide. And I imagine as someone new to the group, it would be great to see a future for yourself that looks like someone is in a place of stability. But I imagine it's re-traumatizing for folks to see someone who is freshly dealing with that trauma.
and yeah, and that Noah, that was my experience. My wife did not have that same experience, but yeah, it did open up new wounds to see people freshly coming into those groups who had just experienced this when we were at a different level of grief at that point. But for me. It was difficult, but there were a lot of people that showed up too. So they didn't have the same experience that I did.
Sure.
Yeah, but
So, how can those of us who are, maybe friends or distant family, talk to someone who has lost a loved one from suicide?
yeah. So this is a great question as well, Noah. When Clay passed away, there we had a huge outpouring of support. And while people were genuinely concerned, they were genuinely cared, they didn't know what to say. And frankly, we didn't really know what we wanted to hear at that point, right? We really went through some of the denial phases, as crazy as that sounds. I convinced myself that this might have been a joke that he was playing on me. It was crazy that I was thinking that. But anyway, people didn't really know what to say to us. But the best advice that I got was avoid the what ifs. A lot of when we went through this, we kept swimming in this sea of what if I had said this? What if I had done this? What if I hadn't said this? What if I hadn't done that? And you never get answers to those questions, but what you do is you answer them in your mind, and in your mind you traumatize yourself because you're thinking, well, if I had done this, he would still be alive. He wouldn't have chosen to do this. And so that advice was very important. And honestly, I did not implement that advice until much later. The other thing that I would advise if you're talking to somebody like this is let them share their experiences with the person that they lost. You know, make some time, sit down, empathetically listen to them, and know that you may be there for a while. Um, and it's not unusual for, even immediately following my son's suicide, there were times when we were actually laughing. That doesn't mean we weren't coping, but it means we were reflecting on some of our experiences with Clay. So, it's okay for you, if you're talking to that individual, to laugh with them. That is perfectly okay. Um, and that's the biggest message that I think that I can give today is with this group of people who have lost people from suicide, is listening. The other one is with people who are contemplating suicide, absolutely sit down, listen to them, know that it may be an hour or more that you're going to need to listen, but that is the best gift that you can give both of these groups of people.
Thank you so much for sitting down and talking with us today. I think this has been great information, and it did elicit some questions from the group. So if we've got some time here, I'd love to kind of field them towards you. One of the first ones that came in essentially is asking if there's a way to project suicide rates in children if we return to school versus having virtual classrooms. Just talking about mental health concerns in the school setting.
Yeah, and that's a great question. I don't know. I mean, I don't want to say I don't know, but I don't.
That's fair.
And the reason that I say that is the same things that I was saying about, is COVID impacting our suicide rates right now? It very well may be. I do know that schools in general have some very, very tough decisions to make, right? If we reopen, then we're putting people at risk, for possibly contracting COVID. If we if we don't reopen, there are sociological and educational consequences for that. So the answer to those questions is yet to be answered. But I would recommend the same thing about listening, talking to these children. This group of children is kind of they don't really readily come out with information, right? So you got to kind of dig it out of them and ask them how they're feeling.
And I'm not a counselor, and I wish I was, because that might give me some better insight into people. But I imagine that a resource about warning signs or conversations for parents or even professionals during this time would be useful if you think there's an increased risk of suicide for a variety of reasons. So that might be an opportunity for follow-up.
Sure.
Another question that came in is the phrase committed suicide places blame on the individual and suggests almost criminal intent. How do we most effectively shift the thinking and vocabulary to died by suicide, which gives grace to the individual who may be going through more than what is visible to those around them? So kind of shifting our vocabulary about committed suicide versus died by suicide.
Certainly, and that is a great question. And I don't know if y'all picked up on it, but I did not say committed suicide in my conversation for that very reason. I think we do need to change that verbiage and say things like die by suicide. I understand that committed suicide, right? We can't commit. I mean, we're not allowed to commit murder, right? There's a law. Well, it's the same thing as we're not supposed to commit suicide. So it used to be considered a crime. Do we want to criminalize those individuals? I mean, those individuals are likely have gone through an extreme mental health crisis that has led them to that. And so it does show much more respect for those that have died by suicide by using that exact verbiage. So that's a great question and a great point.
Well, and I think, again, not knowing anything and verging, going out on a limb here, to criminalize a health condition, I think it goes against the grain of the social justice movement that is on the forefront of a lot of minds right now, and which is very broad as well.
Sure.
Another question, how do you best celebrate the life of an individual who you lost to suicide instead of dwelling on how you lost them?
That's a good question. And I can only speak to my personal experience. So we don't celebrate. I don't think we celebrate. I do know that I'll take off. I always take off that day. We absolutely go to the gravesite. We may go to dinner as a family, and as my family is getting older and moving out, that's a time when we will all get together. And it's not just the anniversary of the suicide itself, but his birthday. You know, on his birthday, we'll put balloons, flowers on his grave. Another thing, I don't know what the audience is going to think about this. I'm certainly not recommending this, but my son, he liked to dip snuff. And so we would put a can of snuff. I've never bought snuff other than for that reason, but that's what we would do. So
I think that's charming, and as long as no gums were harmed in the purchase of snuff, I think it's probably okay. How would you deal with someone who may have survived a suicide attempt? That's a new question that came through.
How would I deal with somebody who survived a suicide attempt?
Maybe talking with them, or do you handle them with, kid gloves, or do you give them arm's length, or are you open and honest with it, or does it depend on the situation?
No, well, it does depend on the situation, but yes, same thing about actively listening to them. Don't treat them with mental health and suicide has this associated negative stigma. And I think that, along with not referring to committing suicide, needs to change, right? We don't need to have that stigma. We need to encourage that individual to talk. What led you to this decision? What was going on? How can I help you? And remind them that, man, I really want you to live. I think, again, listening to them, encouraging them to talk, asking some very open-ended questions, but also have the understanding that you may get some pushback. Some of these people, as I mentioned, withdraw. They may withdraw from you. They may not look at you. They may turn their back to you. But just persevere through that and try to continue to have that conversation.
Excellent advice. This is our last question. It's not really a question so much as maybe rhetorical or a suggestion, but is the Health Science Center considering hosting a QPR training here for faculty and staff, or maybe even students?
I don't know. I know that I went through, I didn't go through the training, but I went through the QPR presentation that I believe was given at the UNT Dallas campus. But I think that's a worthwhile. I mean, if the university would support something like that, I do plan on going through the training myself. Then yeah, I think that's a very worthwhile venture, especially, when you mentioned the 15 to 34 age group, and Noah, you mentioned that there may be people that are even listening today that may have been touched in some way by suicide. The 15 to 34 age group includes our high school students, our college students, likely some of our medical students. So I think that's a very, very good idea. Absolutely.
Ooh, just came in through the comments. The Jordan Elizabeth Harris Foundation, which is local, is providing virtual QPR training throughout the rest of the year, and all are welcome. It is free to attend, and the link is, the website is Jordan Harris Foundation, all one word, .org. So Even better.
Whoever shared that, thank you so much. I was not aware of that. That's
Christy
awesome.
Wiley with the
Thank you
save.
very much.
Okay. Folks, that is it for today. John, thank you so much for discussing this with us. We had a great response from the community and our institution, so I think this topic was very timely and worthwhile. And thank you so much for your openness and honesty and time today to kind of talk and share about it. So thank you.
Certainly. Thank you, Noah, and thank you all for listening.
All right, we'll send the recording out as soon as we can. Y'all have a great day. Bye.
Bye-bye.